Good morning and good evening to everyone. Luca, the medical president of the European Society for Pediatric and Neonatal Intensive Care (ESPNIC), and it's my pleasure to have you here for this webinar. Who kindly have to acknowledge the support of Chiesi Pharmaceutical, a company that, as you know, is very much involved in pediatric and neonatal critical care. And it's a pleasure to tell you that we have more than 1,000 registered attendees, and this is a little bit like the average that we're going to have on all the webinars, all the educational ESPNIC webinars. It's a pleasure to see all these people interesting, and ESPNIC is here to help you and to improve your quality of care and to connect you with the key opinion leader in the field of neonatal critical care. And it's also my pleasure here to introduce you to very big key opinion leaders. The first one is going to be our moderator, our chair, Professor Nina Modi, who needs no introduction, full professor of neonatology at the Imperial College in London, and many, many other things. And she will be moderating our good friend, Professor Roger Hall, full professor of neonatology at the University of Vermont in Burlington in the US. Roger is very well known for all his researches and particularly all the Cochrane reviews, but today is going to speak about a very important thing about how to translate quality improvement projects and improve our quality of NICU care. So I'm leaving the stage to you guys, and I'm very happy to listen to you.
So hi, I'm going to try to share my screen with you. So give me 1 second just to get this right. Can you now see my slides? Excellent, thanks. So let's get started. When I got on the line with Professor De Luca and Professor Modi, one of the first things we commented on, this is too bad, of course, that we're not talking in person, but it's still truly my pleasure to have a chance to talk to you today. We'll have about half an hour for me to talk to you a little bit about quality improvement with a specific example of using BPD as one of our outcomes. And then Professor Modi will lead us through some moderated question and answer, which I look forward to. From a point of view of faculty disclosures, I am the Vice President of Vermont Oxford Network, Coordinating Editor of Cochrane Neonatal. I'll be using examples from each in this talk, and I don't believe I have any other relevant issues to disclose. What I'd like for us to do in the time we have is to go through a few basic points about how to do quality improvement in your NICU. I'd like to discuss how to use available data sources to evaluate your practice. I'd like to understand why we would choose a given measure and how we can determine how we fall in our performance on that measure by benchmarking. Understand what potentially better practices might lead to improvement and how we evaluate if change has in fact led to improvement. And let's just start with this example, a snapshot of our practices. I'm looking here at data from the Vermont Oxford Network, and I've narrowed it to a population of infants between 27 and 29 weeks, in part because I really believe it's a population that, A, we all attempt to support in our intensive care, and a population where the evidence base has been developed. And let's take a look here at both the lowest quartile, which means the point at which a quarter of us do that amount of intervention or less, and the highest quartile, the cut point where a quarter of us do that percentage of the intervention or more. And we'll take a look at something as, let's say, delivery room Cpap here. You can see that at a quarter of our hospitals, 22% or fewer infants are supported with Cpap in the delivery room. And at a quarter of our hospitals, 56% or more are supported. The same if we go down and look at delivery room surfactant administration. At a quarter of the hospitals, this isn't a practice that's utilized. And at a quarter of the hospitals, more than 36% utilize it. Importantly, we want to know, does this change in practice look at change in outcome? And you can see here that there's definite huge variation in outcome. Looking at just the rates of mortality here, we can see in this population, some of our centers, a quarter of our centers report no mortality, and a quarter of our centers report 11% mortality or more. Today's talk will be focusing a great deal on BPD or chronic lung disease, and here again we see great variation, with a quarter of our centers reporting 7% or less, and a quarter of our centers reporting 31% or more. So then the question is, what causes that variation in outcome? And some of it is quite obvious. We know that case mix will determine that. I work at the University of Vermont, a university hospital serving a population of around 100 to 150 mile radius, but really not a referral hospital for specialty children's care. That would be Boston Children's Hospital down in Boston. And you would not expect my hospital and Boston Children's seeing sicker babies to have necessarily similar results. There's always random chance as well. Every one of us has known a week or so in the NICU where we've looked up and said, I can't believe all these sick babies are coming in this week. And so we know that there are fluctuations in the degree of illness. But even when we correct for case mix and random chance, we see that there's a large amount of unexplained variation in outcome. And the core issue of quality improvement is that reflected by the effectiveness of care. What are some of the sources of unexplained variation? Well, unmeasured risk in the population. But from a point of view of quality improvement, we want to know whether or not changes in practices, processes, people and staffing, and organizational structure, in fact, impact on these outcomes. So our first step in quality improvement is to understand our practice and to look at our available data sources. And I think at this day and age, we all have a variety of available data resources at our fingertips to begin to inspect our practice. I'll be using some examples from our database, so-called Nightingale, named after Florence Nightingale, who was in fact one of the first perinatal epidemiologists in modern record, to discuss that you need to have reliable data and you need to pick from that the measures that you want to evaluate. Now, this is a pretty busy slide, sort of a landing page in Nightingale, taking a look, as you can see on your left, at a variety of important key outcomes. But for today, we're going to focus on chronic lung disease. If we read through here, this column is my theoretical center, here, Center 99, and they have a 50% rate of chronic lung disease, compared to an average network rate of 24.4%, with the first quartile being 10.3% or less, and the third quartile being 30.6% or greater. So you immediately know, if you're this imaginary Center 999, that you might have issues regarding chronic lung disease. Here it's portrayed in another way that might be simpler for you to quickly grasp where your center might want to look at. The dot here is the theoretical center's performance, and the bar is the first and third quartiles. And you can see that my Center 999 is an outlier with worse rates of chronic lung disease. Importantly, we all have bad years and we all have good years. You want to look over time to understand, is this in fact a persistent problem? And here in this theoretical center, you see that it is. For the past 2 years, there have been high rates of chronic lung disease. And in fact, they rarely in the past 5 years have even reached an average rate for the network. So a little bit more on measures. Are the measures you choose meaningful? And I think this is an interesting issue for quality improvement, and that is moving from our mindset about what an appropriate outcome might be for research and understanding what an important outcome might be for quality. And there's a fair amount of discussion on this point. Research has a different purpose. Research wants to discover new knowledge and uses tightly controlled tests to gather as much information as possible. And frankly, most of our important research, because of the numbers we need to generate, takes years to accomplish. Quality improvement seeks to implement current knowledge and conduct small sequential observational tests. This is work that isn't funded, and you want to gather just enough data to make it meaningful and use multiple short test cycles to see if you're making progress. So let's take a look at measures. I think we are all familiar with the fact that when BPD was first described, it was a 28-day outcome. but most of us have come to see the outcome as something that needs to be viewed through the lens of corrected gestational age. This is the original work of Shannon in 1988, showing that not until you required oxygen someplace between 34 to 36 weeks adjusted age, did you begin to have a population in which more than half of them had abnormal pulmonary follow-up. This definition has been toyed with and adjusted now so that we have a progression of definitions in many ways of increasing complexity, which may be very important for our research agenda, but not so easy to address vis-a-vis our quality agenda. Here's a cartoon referencing American football of moving the goalposts to make your scoring easier. And I think that some of the impetus has been because we've made little impact on BPD and few of our recently tested interventions are that potent, that there's a temptation to say that the problem is with the definition and not, in fact, with issues around care. Here's some work from the Canadian Neonatal Network, which I think highlights the fact that some of the simple definitions still have a meaningful quality both to our patients and to ourselves. And so here we look at the traditional original 28-day definition, and we see it has very poor value in assessing the risk of adverse outcome and is consistent with having no impact to having impact. But by the time we get to the 36 weeks adjusted age outcomes, we see that all of them are predictive of adverse outcome and therefore have some meaning. Now, that's not to say that for our research purposes, we don't want more refined definitions to pick out the sickest babies that we want to impact on. And if I was doing research on, let's say, stem cells, I would use a more sophisticated definition. But we're talking here about quality improvement, and so we're talking about a very pragmatic approach. Let's talk a little bit more about measures. What processes would you follow, and what balancing measures might exist? Well, clearly, one of the issues for improving outcome might be the use of less invasive respiratory support. And so you would want to follow your use of Cpap in this population. Here, just looking at my theoretical center, we can see that, in fact, the use of Cpap is high, despite the fact that they have poor outcomes regarding BPD. Another balancing measure might be the use of postnatal corticosteroids, something that we see as deleterious to developmental outcome, even though it is very impactful on BPD. Looking at the Vaughan data between 1994 and 2015, we see a dramatic decrease in the use of postnatal steroids, and we see little improvement in chronic lung disease. Now, there's disappointment that we haven't seen as much improvement in chronic lung disease as we might like. But you know, there is actually a message there to say that we are exposing our infants to less postnatal steroids without increasing chronic lung disease. And so some people might argue, from the point of view of a balancing measure, that there is some success to be seen there. Let's take a second about how not to do quality improvement. And I'll give a historical example. I think you're all familiar with the work of Semmelweis in Austria, where he looked at postpartum puerperal fever and demonstrated the impact of hand washing with a dramatic decrease in mortality on the doctor's service when they introduced hand washing from 18.3% to 1.3%. This seems to be a huge success. The fact of the matter is, and the untold part of the story, is that the Austrian hospital never adopted hand washing as a quality improvement, and in fact rejected Semmelweis's thoughts on this. When Semmelweis was told that this wasn't happening, his friends and supporters told him, go out there and repeat the experiment, show them that it works, sell your idea. And he said, no, I've proved it, and there's no more to say. And so although he had a fantastic quality improvement idea with a strong evidence base, his position in the hospital, his lack of vision regarding leadership, led them not to make any of these changes. And he died disturbed, penniless, and unrecognized for this work. Don't let that happen to you. What you want to do is learn how to do quality improvement. Data, as I alluded to earlier, are necessary, but they're far from sufficient. You need to create teams of individuals who are motivated, are trained, and have the skills and tools and resources to perform quality improvement. I'm going to use an example from Vermont Oxford Network's initial work on quality improvement, but there have been many, many examples since that time. But I'll talk about one of our original projects in 1995, where we formed multidisciplinary teams that worked together under direction of a trained facilitator over a 3-year period. This group received instruction in quality improvement, reviewed their own data regarding performance, delineated common improvement goals, and implemented what I refer to here as potentially better practices, practices that have been shown to have evidence experimentally, but are potentially better, and you don't know that until you try it in your context, and developed quality improvement plans. There were a few behaviors that we thought were very important for the quality improvement groups in order to succeed. We thought that groups had to develop a habit for change. And what I mean by that is an openness to changing current practice. Now, change is not good for change's sake. All change that we do should be because we think it might lead to progress and improvement. But the fact of the matter is that all human beings, or most human beings, are resistant to changing their habits, and you need to develop an openness towards that. You need to have the habit for evidence-based practice to demand that there's a careful look at the evidence behind the practices that you're considering for change. You need to think through the complex systems we work in. It's not as simple just as one person saying, I'm going to improve this. It involves a team of people, and you need to think that through. And then we need to learn the habit for collaborative learning. And that's in fact demonstrated by us sharing this seminar. We want to learn from others. We don't want to recreate the wheel. We want to look at what people have done that is successful and co-opt that. We joke about stealing shamelessly from our colleagues. There's no reason not to think and read the quality literature and to see what has shown some effect. It seems very important that there is organizational buy-in in order to succeed at quality improvement. This is part of a culture of your unit, a culture of your hospital, and a culture of our field that I think has shifted in the past 10 years to understand the importance of this. My training, 1970s, the people I admired were the individual brilliant physicians or nurses that I met, as opposed to understanding that we need to work as a team. And then what sort of team are we? Clearly, there are hierarchical structures which lead to no good benefit. And yet there's also structures that lead to great efficiency and speed. And so we really need to think about teamwork, how we treat our team members, and the leadership of those teams. So where do change ideas come from? Well, using BPD as an example, there are myriad change ideas. In our understanding of the pathophysiology of the underlying disease, we've recognized that there is a highly variable clinical phenotype, which there may be various different factors that affect it. So everything from the epigenetic and genetic predisposition to the disease to our exposure to mechanical ventilation may all impact on BPD. And we need to understand both the individual patient's problem and how our improvement efforts may help that. There are so many possible evidence-based interventions that have been discussed. You can see just a few here. And so there's a myriad of things to look at. Evidence-based medicine does give us those change ideas. It's the do what of quality improvement. But what we really want to focus on today, and when we think about quality improvement, is the do how, the so-called evidence-based practice. This gets to this issue of efficacy versus effectiveness. Efficacy is something we see in the tightly controlled setting of clinical trials, where we have paid staff and commitment of that staff and careful introduction of the therapy. But effectiveness is what happens in the real world, where everyone is getting the therapy across every shift without monitoring it the same way. And frequently results will differ between clinical trials and effectiveness studies. An example of this difference between efficacy and effectiveness is pulmonary surfactant. I don't think there's any debate about the fact that pulmonary surfactant decreases the risk of pneumothorax in preterm infants with RDS. But we don't know in each unit which patients are we going to give it to, at which dose, using which product, who should be administering the treatment, at what time do we treat the babies, and when and do we need to retreat the babies. When you think about the problems you want to address, you need to choose the right project. I gave you the example earlier in my theoretical center that BPD was an important project for that center. It's the right project. It's important. It's relevant. There is evidence behind it, and the goals are achievable. Some of the quality improvement tools we use are this here, the PDSA cycle of careful planning, then enacting, and then studying with our data changes, and a constant cycle, an iterative cycle. We need to set our goals such that the aims of them are clear and definable, so-called SMART aims. They are specific, measurable, attainable, relevant, and timely. We expect to see these changes in a time frame that is important to our patients. We need to analyze what is going on in our unit about what drives these processes. So for example, the primary driver on BPD could be aspects of antenatal care with all the secondary drivers about mode of delivery, resuscitation at delivery, use of antenatal steroids. Another primary driver might be use of mechanical ventilation or avoidance of mechanical ventilation, with the secondary drivers regarding Cpap or time of surfactant therapy, etc. How will I know I made an improvement? Well, you can look before and after. Here an example of improving Cpap in the delivery room from 79% to 86%, but that's probably a fairly crude way to look at your data. Here's just an example of how if we chose those 2 time points, it looks like there's an improvement, but in fact the improvement was going on beforehand and was actually decreasing then. And so we missed the fact that we're not really making the improvements we want. You need to take a look at the more current tools like run charts and start to learn how to read run charts in order to interpret whether or not the changes you made are leading to improvement. So let's just take a look at examples of impacting on BPD through quality improvement. I'm going to give examples through the Vermont Oxford Network collaborative work, but there are many others to choose from worldwide. Here's the example I alluded to earlier that was done back in the late 1990s. It looked at 10 self-selected NICUs who were educated about quality improvement and chose their topic, 6 working on infection, 4 working on chronic lung disease, with the rest of the network, 66 centers at the time, serving as contemporaries results. For nosocomial infection, the group decided to look at hand washing. And I'm joking here, but it really should be hand washing and hand washing and hand washing, but also guidelines for central line placement, skin care, blood culture techniques, and what they defined as unit culture, the belief that nosocomial infection was a serious problem that they were responsible for, and not just the birthright of being sick and in a NICU. For chronic lung disease, and again, remember, this was the late 1990s, they wanted to increase the use of antenatal steroids. They wanted clear policies and guidelines for surfactant use, less use of invasive respiratory support, appropriate use of postnatal steroids, improved nutrition, and vitamin A. They did the projects, and they found that there was a decrease in nosocomial infection, as well as a decrease in chronic lung disease or death. There are economic implications of these improvements. It takes money to get together as teams and start this whole process. But in fact, there's potentially millions of dollars overall to be saved by this commitment by decreasing issues like infection, which are costly and add days to hospitalization of our preterm infants. This work has been replicated by various other efforts. Here, taking a look at the so-called Breath Savers Group, a different quality improvement collaborative involving 19 hospitals. This is a grid of what they consider to be their best practices and the participating centers and what they introduced. Again, we could go through the practices on the left, But I think the important point here is that not every center in this collaborative chose to do everything identically. They looked at what they needed and what they had resources for. And some centers, for example, didn't have the monitoring equipment and did not do this. And so for each center, you have to individualize those needs. They found decreases in chronic lung disease. BPD dropped significantly. They also found improved survival, though that was not statistically significant, and decreased severe retinopathy, IVH, and use of supplemental oxygen. They used less conventional ventilation and less postnatal steroids as well, and increased their Cpap use. Again, this work has been done by many different networks and centers. Just to finish up, here's a wonderful example from the Canadian Neonatal Network that did a cluster trial in infants less than 32 weeks. And they did a year of data collection and then second year of practice change. Their interventions were much more widespread and sweeping than the recommendations I showed you, and really addressed all aspects of care, from antenatal management, delivery room management, use of Cpap, mechanical ventilation, and so on. Here are just some of the detailed, potentially better practices suggested by the Canadian network. And again, I won't go into them in each stage, but I think you can see they thought through in each phase of care what they thought might be an evidence-based practice that might lead to improvement. And this is true across all of those domains. What they found was a decrease of both of BPD and infection in both groups. They showed in year 2 here a 6% absolute difference in the incidence of BPD and a 5% decrease in the incidence of infection. So again, I focus on the fact that we all recognize what evidence-based medicine is. And I think that the community has developed an appreciation for that. But the real trick is understanding how you are going to use that evidence and how you're going to contextualize it to your unit. And I'll just end with an example of the types of changes that we have seen in the previous years that I think there's a great deal to be proud of. This is data from Vermont Oxford Network looking at variation in performance. And this is just charting the rates over time between 2005 and 2014. And I think we have seen a remarkable decrease in the risk of mortality. We've seen a remarkable decrease in the risk of late onset infection and in severe retinopathy of prematurity, but less so when we think of outcomes such as chronic lung disease or necrotizing enterocolitis. Here's an interesting way of looking at the data. Here on the left is the starting point of everyone at the 10th percentile and at the 25th percentile. And that's obvious at the starting point. But here it's plotting how many centers have now matched what was the 10th percentile in 2005 as they go through time. And you can see that as we progress through the 10-year period, all of the centers are doing as well as the best centers from 2005. This is true of late onset infection. This is true of serious ROP, but not so true of our outcome of chronic lung disease. So by 2014, more than 75% of NICUs had learned to perform as well or better than the best 25% of NICUs in 2005. And I think that part of this is likely due to a commitment of using quality improvement. Quality improvement has proven to be a core activity, and the evidence is accumulating that these initiatives are quite successful. So I'll stop here and open to comments and questions. Thank you.
Thank you very much, Roger, for giving us a really good overview of quality improvement. The questions are coming in, but I'm going to kick off and say to you, isn't quality improvement just practicing really good medicine and doing it collaboratively?
So yes, but it is perhaps more than that. I mean, you mentioned collaboratively. There is a culture to quality improvement. But Talden has a quote that we all have two jobs, One is our regular job, the doctor, the nurse, the respiratory therapist, and the other is quality improvement. The problem is, of course, that we're only paid for one job, okay? And so it's easy to say, and I think we all would agree that it is the best way to practice, but it's a little harder to do. And I think we have to see, you could be the best person in your little silo, but as you mentioned, Nina, it's the collaboration that makes the difference within the unit and between the units. And so, yes, quality improvement is what we should all aspire to. It really is quite simply what we should be doing and our best medical practice. But I think it requires some more insight and commitment.
Great. So I've got a question here from Mika Nonayama, who asks about the difference between quality improvement and implementation science.
I'm not sure I know the difference. I think more and more we have tried to understand how to best disseminate these findings and how to best do it. But I think the quality improvement brings us down to our individual units. So and I may not be quoting this right because I'm not sure I understand the definition fully of implementation science, but there is a science about how people perceive, how people change, how we can encourage change, how we can lead, that we do need to learn. But there's always our own unit and we are all different. And quality improvement takes it to the bedside in our own unit.
And a couple of questions from some delegates who prefer to be anonymous, and they asked a very insightful question. How do we make the changes stick? How do we ensure continuity?
We don't, unfortunately. Recidivism is classic when we look at nosocomial infection. It's like my weight loss plans. They can work for a month or two, but recidivism is real, in part because of what I alluded to earlier. We don't have necessarily the institutional commitment, the time and the pay and everything that it takes to make things stick. So we say, we're going to focus on hand washing. We're going to put up signs about hand washing, big signs about Bob, beat out bugs with a caricature and telling our nurses talk to each other, or empowering the parents to tell you, hey, did you wash your hands before you saw my baby? But these things do frequently die on the vine, and that is a big part of quality improvement. It's a great question. If you commit to these things, you need to revisit them. You need to continue to measure them. If you see yourself falling off, you need to reintroduce it. It might be an argument, Nina, for not biting off too many quality improvement projects. I think right now we see lots of units which will have, 8, 9, 10, 12 things that they're considering quality improvement. And they may not recognize that you have some opportunity costs there, that you have to sustain these things. And so once you see something is working, I think you have to commit some resources to sustaining, and I think that's frequently lacking.
Roger, when you gave the keynote David Harvey lecture at the Neonatal Update last year and wrote a very insightful paper on the basis of your lecture, and one of your comments really has resonated and has stayed with me. And you said quality improvement is great when it's done well, but there's a danger that the focus on quality improvement is detracting from research, and randomized trials are falling in number. So I'd like to hear your views on that 1 year on, but also to extend the question, if I may, because I very often hear colleagues from around the world saying, well, we've implemented a quality improvement program which is designed to do X. And I say, but hang on, there isn't equipoise about X. There isn't a good evidence base for X. You may think that X is the right thing to do, but Dr. Y over there is doing something else and absolutely put his hand on his heart and says, I know what's right to do. So is there a danger with choosing measures for quality improvement that you impose a non-evidence-based practice on every baby, and that too acts as an impediment to good evidence generation?
Well, thank you, Nina. First of all, I very much enjoyed the invitation to give the David Harvey lecture and to bring out that perplexing point that I secretly do hold. I came to the field of neonatology through my introduction to randomized trials, through Jerry Lucy introducing me to Bill Silverman, to the opportunity to do trials on surfactant, and meeting Ian Chalmers and Adrian Grant at the National Perinatal Epidemiology Unit. And I'm a firm believer that we can and should be doing more trials, and practical trials, pragmatic trials. I have seen that idea, at least in the United States, wither on the vine. I am shocked at the fact that it's so difficult to recruit centers to participate in trials, at least in the US. And whether or not that has to do with the regulatory process, but also I think the sense that, hey, we're all tied up doing this QI work now. That's where our volunteer resources are going. The resource you attempted to tap into, Roger, of, hey, we could all do this along with our job. If you're just giving 1 aspirin or 2 aspirins, we can do that and collect data on death and find out a lot about thousands of patients, has never borne fruit. And I think part of it, like I said, is a regulatory issue, but a great deal of it is a cultural issue. And I am concerned that people are now consumed with QI and not as committed to research, which is where we get the QI ideas from. So, it's bound to fail if that's the approach we take, and or supplement now into the old practice of just looking in a sort of expert choice now becomes group choice, but it's still just a choice as opposed to an evidence basis. So long-winded answer, Nina, but I stick to my insights a year ago and remain concerned that the community at large has turned its back on the trial evidence because of the difficulties, and in embracing QI, which is a good thing, but has filled up its capacity with that type of work, when in fact we should be doing both.
Well, we share that concern, Roger. And your comment about the choice of measure in a QI project and the danger of imposing a clinician's bias and a non-evidence-based practice. What are your thoughts there?
Well, the choice of measure is interesting. You heard me talk a little bit about BPD, and I think that most of the community disagrees with me on this. Most feel that we really do need a more precise definition and that it's important. And many people feel that if the precise definition is what we're aiming for, that's what should be used. My concern is that outcomes need to be practical. Here's a simple example. You can try to get BPD data at 36 weeks adjusted age or at 40 weeks. But the fact is most of our patients are home by 40 weeks. You would have to set up a whole new data system. And maybe the answer back to me is, well, we should be tracking our patients out there and there should be such a system. But even so, simple, meaningful outcomes, I think, have to be the core of QI. QI sometimes can just be, oh, I want to get antibiotics in before an hour after admission. It can be a process thing. Is that meaningful? Possibly. And should your unit be looking at things like that? Possibly. Issues like nosocomial infection and BPD, I think, are universally agreed upon as having some downstream meaning or NEC. And so we do have in-hospital outcomes that I think are still meaningful. Our problem really is that the evidence basis is spare, and not so much that our outcomes are meaningless.
Yeah. Well, I absolutely agree with you there. Now, there's a question from Christian Poets who says, thank you very much for a great talk. Christian, I'm not sure if I understand your question, but Roger may do better than me, and you may want to come back in with an amendment. But what Christian says is, why is it just BPD that's excluded from this improvement? In other words, what's so special about BPD?
Well, I'm guessing, and Christian, hello, and please do come back in if I don't really address the question. I chose BPD as the example because we haven't made enough improvement. Okay, it would have been simple for me to choose nosocomial infection and be a huckster for QI. If you want to work on nosocomial infection, you succeed. My advice to everyone who's starting out is to choose nosocomial infection. because there's a lot of structure and organization that will be positive if you get the group together, and you'll have success. Almost every time people have focused on improving hand hygiene and improving line placement, they've decreased their rates of nosocomial infection. And so I could have structured the talk with that as the outcome of interest, but that seemed to be a cheat, frankly. So I wanted to choose something that's more of a challenge. But any of these outcomes are reasonable. And part of looking at your data is deciding, oh, I'm pretty good at BPD, but our rates of severe ROP are off the wall. And then you're going to evaluate DR stabilization and oxygen use and monitoring targets, et cetera, and nursing ratios and all sorts of things that come from evidence. So I've got no issue. I don't play just for BPD. I don't think our quality should only focus on that. Far from it. Our quality issues are dictated by your performance and where you want to improve. I've chosen an example just because so many of us are struggling with it.
Thank you, Roger. Now, a very interesting question about implementing quality improvement in developing countries and starting a lifelong strategy of quality improvement in the developing developing country neonatal units.
That is a question that is near and dear to my heart, and one that I don't think has been explored enough as of yet. At Vaughan, we do have relationships in many low and middle income countries, and we even have whole networks such as Ethiopia, where we are focusing on this work. Here's some of the issues and not all of the issues. One, what I alluded to about everyone has two jobs is even harder when you barely have enough people to fill the one job. So it's asking a lot to do quality improvement at the level that I'm talking about. Two is that systems need to address the breadth and the multidisciplines, and cultures differ between the high income countries that I usually work in and the low and middle income countries. And I think that that is a shift that has to be explored by those units. What I love about quality improvement in those situations is this whole idea that you identify in your context, in your hospital, what you think your issues are. You look at the evidence base and say, we have these resources or we don't. Sometimes that leads to an argument for getting those resources. Other times it is an argument of, well, we can't quite do it that way, and we have to modify it. And of course, modification means it may or may not work as well in your unit. I'm sure we're all contemplating some of the recent cooling trials from the subcontinent and wondering why it did not work as well in those recent trials. And part of it may be that the populations were different. I don't think that they cooled poorly. I just don't think that in their setting, they selected the right population that would benefit. And so there's a lot to taking the evidence and applying it in a different setting. There's a lot of working in a different setting that requires different thought about who will be the leaders, who can I expect on my team, how much data can I collect. But I think it's very important, and actually some of the most promising. People such as myself from high-income countries should not just look at the evidence available to me and think it's going to apply to low and middle-income countries. And I think quality improvement, not just other trials of it, which may be important, but even those centers doing active quality improvement, understanding their context, et cetera, is a huge way to go. And I really endorse the process that introduces more of these efforts into LMICs.
Now, Roger, there's a question here from Karen Light. Karen's a colleague of mine in the UK, and she's running a major national quality improvement program. She has a question. How do we close the implementation gap between randomized controlled trials that demonstrate that an intervention is effective and then universal clinical use, which she says it still remains about 10 to 15 years?
So that whole issue of the gap, the evidence gap, is perplexing. I am as perplexed by what we discussed earlier, Nina, which is that we're actually not creating enough evidence to identify the gaps. So, I mean, that's to me, the major current stumbling block. But then there's also the issue of existing evidence and who has guidelines, et cetera. What will people do, for example, about the emerging evidence on less invasive surfactant therapy. What do we know about that? And I'm alluding to the thin catheter administration. Is there enough evidence? I might argue there is. Are centers looking at their guidelines and procedures and beginning to adopt this from a quality point of view? I don't know. And I certainly know it's more complicated than it seems. I'm not so sure that intubating with a little piece of linguine is something that everyone can do effectively. And if you wanted to do it to close that gap between where I think the recent evidence has taken us and quality, it's a big step. You have to agree that the evidence is there. You have to train people then into this procedure. You have to decide how you're going to do it. One person, two persons, syringe with an angiocath, feeding tube, etc. So it's always hard, even when you think there's evidence there, to truly jump that gap. It takes a lot of effort. I'm not sure that gets to the core of the question, because part of the question is, are people even aware of that evidence gap? But perhaps we can discuss that later.
Now we have another question about, this is from Rita Silvera. She says, how do you measure outcomes in different settings? So, for example, if centers don't have the same practices, and by that I presume she means they may not be measuring the same things, or they may not be capturing the same data. How do you measure outcomes in different settings in order to establish a strategy for quality improvement?
Well, that's an argument for networks such as yours and mine, Nina. They should have similar metrics. It's very hard not to. And I guess the question there is, let's say that I wanted to do something with Nina in the UK. We have to iron that out. And that's a reason for people worldwide to be working on common definitions and moving in that direction, because collaboration should be broad. But it's hard to know. It's even hard to know how people count death worldwide. Did they get the delivery room deaths into that equation? Did they count everyone, or did they forgive themselves for deaths that happened before 6 hours of admission? So that's difficult. But benchmarking is not useful unless you do have those common definitions. And your question is more of an argument for creating commonality of definitions than imposing anything on it.
That's very interesting. So perhaps that too could be translated to the developing world, more collaboration with benchmarking, sharing, and viewing.
Yeah, we have tried to create a database for just that purpose, Nina, not like our database that we use in the core VON database, but a database for sub-Saharan Africa, which looks at markers that they're already comfortable and familiar with collecting, markers that are more meaningful to them that in fact we may not collect in our data, but are very meaningful in that context. And so agreeing and working on those things is step one.
Now, Maria Lag says, patient safety and quality improvement is still not an issue that's considered important or of clinical relevance to medical students. What's your comment about quality improvement at medical school?
Wonderful question. I'm not sure what the situation is like worldwide, but it certainly has been introduced into our postgraduate education. So our residents all do quality improvement projects and are introduced to this. But there is no reason that this should not be part of the core education at the medical student stage. There is a lot to learn. One of the problems might be it's harder to make that actionable at the medical student level, give them a project. Perhaps their project could be more educationally oriented than clinical outcome oriented. But there is a lot to learn, and it would be a good time to introduce it. I alluded to reading run charts and the rules of quality improvement, or the Pareto charts that look at what the majority influence on a given outcome is and orders them, are all very teachable as a formal curriculum and would be very amenable to medical student teaching. Right now, I know we do it at the residency stage because we give them clinical quality projects. And I think that's true in pediatric residency throughout the US, but there's absolutely no reason not to have a curriculum regarding quality for medical students. It would be a good time to introduce it.
So all those future deans out there, pay attention to that comment. Now, from Abdul Monem Benarus, quality improvement takes time. Sometimes one waits for things to go. He says sometimes one waits for events to happen to react. Perhaps you could say sometimes we wait for things to go wrong before we try and make them better. So how can we be faster in reaction and prevent things happening even better than before?
Great question. A couple of things to explore in that question. One is that unlike a trial, you need to be looking at your data a lot in quality improvement. Those PDSA cycles need to be relatively short. Now, that's very hard when it comes to outcomes like NEC, which are relatively rare in a given year. You can't not say, oh, I've improved NEC this month. That's random. And so some things simply will take time. But for example, are you doing the processes you thought? So let's say, for argument's sake, that one of your improvement goals in your NEC project was making sure that more infants got their mother's expressed breast milk sooner. Okay, that you can look at on a rapid cycle and more iterations and say, okay, we're making progress here. And so I'm not sure I'm reading your question right, but yes, it's hard sometimes when it comes to some of the big ticket items to see if you've impacted. But it's not hard if you're looking at, are we doing what we said we'd do? Are we getting mother's milk into these babies in a timely way? That you can look at and correct your errors. And that I said that as one thing, but in fact, there are many strategies that you might say, okay, so we're going to have a separate room. We're going to have better pumps. We're going to give medical information to families. Each of those iterations can be tested. We started this month, we did this, we didn't see a big uptake, so we added that. So if you're looking at improving the processes that you think are evidence-based, you can collapse the time frame. And unlike a trial, the iterations in the PDSA cycle is tight. It is tough, and I think your question alluded to this, for some of the bigger items we want to improve that take time and are harder to assess.
What advice would you give, Roger, for choosing a topic for a quality improvement project? If someone's just starting out, neonatal unit wants to get involved in quality improvement, what advice would you give them for how to choose a starting project?
So it's an interesting question because on the one hand, I think that quality projects should be done by the entire unit and should be done with buy-in from the entire unit. And so the process involves the multidisciplinary group identifying what they think is important. No one wants to put their efforts into things they don't think are important. And so it takes consensus and discussion. It takes, I think, starting point is reviewing your own data. So it's taking your own pulse in these things and agreeing that this is what we as a unit want to do. Those are for big ticket items. But the fact is quality improvement is done on many levels, and some are individual projects that people attempt. Again, choose things that you think are important. Work in teams if you have big ambitions, and use available data sources. Don't recreate the wheel. Those would be my advice.
Great advice, that's. And another tricky question coming here. How long do you think it takes to get quality improvement processes really entrenched into neonatal unit culture?
I've been working at this for decades, along with my interest in trials, obviously. And I still see that it's a difficult thing in terms of our culture. We are, in general, overworked. It's hard to make this stick. How do we do it? Again, I think it has to do with elevating the process and working as a team and setting this goal. It's not an easy thing. We need to talk more to what we call here in the States the C-suite. We need to have buy-in at that highest level that this is an important activity. We need to have supports within the context of our hospitals to both, I asked about medical students. In fact, the hospital has to have supports of experts who can be training people in creating these charts, in how to mine the available data sources. I showed you Vaughan data, but in fact, every hospital has its own data and its own work. Most of us have electronic records now of sorts, who can say, okay, we need these reports from you. And so if you want to make it stick, you need to have support from above.
Take the whole team with you and start from the top. Thank you very much, Roger. I see our chairman looking at me, so I think that's the cue to wind up. We've kept you talking on a very, very interesting subject indeed. And I guess the messages, the key messages for us all to take away. And please chip in and tell me if I'm misinterpreting you, Roger. But first of all, measure what you're doing, because it's only by measuring what you're doing that you will get a handle on where you want to improve. The second point is start with something that you really know is going to make a difference. And you gave a wonderful example of hand washing and line care for invasive lines. We all have a problem with infection. We all need to do something about it. If you're starting with a quality improvement program, start with something that really is, you're pretty sure it's going to make a meaningful difference. Do it in collaboration with your colleagues, achieve consensus. Make sure that the boss of the unit and even the boss of the hospital knows what you're about and is supportive of what you're doing. And then involve everyone of the team, including the medical student who's come along for a 2-week attachment. So your nursing colleagues, your allied health professionals, students, everyone. And then, of course, be wary of not over-egging, if I can use a very British phrase, not over-egging the implementation of quality improvement to the exclusion of other things that also are necessary to improve patient care, such as seeking evidence, which means doing randomized controlled trials, doing high quality observational research, and gathering the evidence. Because of course, without good evidence, we're not going to be able to implement good evidence. And without implementing good evidence, well, where's the quality improvement? So those are my take-home messages, Roger. I'm going to give you the final word. Are there any other final take-home messages for our several hundred delegates?
Well, Nina, all I can say is, wow, I hope I was as clear as you were about the important points. But no, thank you, Nina. And yes, spot on. The biggest thing, and I think you interpreted me 100% correctly, that choose the low-lying fruit to start. But the reason for that is that helps you establish the culture, okay, to get the team into the room, to begin a process. And there's nothing like success to help a process move forward. But even if you choose something as straightforward as nosocomial infection, I advise you to make the contacts with the nursing staff, with the families, with ID if necessary, your infection control people. Create that team and create that culture and use something relatively easy. But the tough part is, okay, how do I get everyone at the table, respecting each other, and moving forward so that we can then take on more challenging projects in the future? But that was great, Nina. It was great. I enjoyed. If I was as good as you were, I'm proud of this.
Roger, you've given us a great lecture. You've given us an absolutely fantastic lecture, and you will see that from the comments coming in. Lots and lots and lots of appreciation of another fantastic lecture. It's also been very good to see you again.
Nice to see everyone.
And I will hand over to Danny DeLuca now. Professor DeLuca.
Yeah, well, I can only copy Nina's words. This has been fantastic, really. I couldn't expect anything different. And I'm happy that everyone would be very, very happy about that. But you know, Roger, we can only learn from you, from your experience. And I'm even wondering if it's a good idea to create a sort of a face-to-face event exclusively dedicated to a QI methodology, because it's the methods that we need to learn, first of all. So maybe a lot of food for toes as soon as we will be able to meet again in person and organize that over there or even here in Europe. Why not? And SPNIC will be very happy about that. So thank you again.
Wonderful. Thank you for the opportunity.
Bye.
Bye-bye, everyone.
Bye-bye.
Very much. Bye-bye.